We wait for 1 minute and then we start. So I think we can just start. There's some more people coming, but welcome to our webinar number 4 from the Climate and Health Initiative. Today we have with us Stefán Hjörleifsson, who is a colleague and a friend, who is going to talk about medical overuse or overconsumption and climate emissions from health services. And then we will have some conversation with those of you here today with us. So I think without more, I think you can introduce yourself, Stefán. You are a general practitioner. You have worked with this Klokevalk, so I don't know the English name for a long time, and you are also very much thinking about the climate changes as well. So I think I'm looking forward to listening to you, but you might introduce yourself better than I have done. The floor is yours.
Thank you. Hello, everyone. Stefán Hjörleifsson, Associate Professor at the University of Bergen at ALREC, working as a medical doctor, as a general practitioner. I chair the initiative that is called Choosing Wisely Norway, or Gjør kloke valg. I'll talk more about that later. Some of the perspectives and initiatives I will mention are conducted in collaboration between me at the University of Bergen and colleagues at the university in Trondheim, and some of them are conducted in collaboration with the Norwegian College of General Practice, the logo to the left. So medical overuse and climate emissions from healthcare is my title, and synopsis of what I'm going to say is, and I'll speak a little bit about emissions from the health services, the extent of those emissions, why they are important, and a little bit about how people are starting to address those emissions. Then what might be more novel to some of you is the concept of medical overuse, overdiagnosis, and overtreatment. The extent of overuse of healthcare services, and then the link. So addressing medical overuse as a way of curbing climate emissions, and then finally about ongoing initiatives in this area, and especially choosing wisely in Norway. So this is what I'm going to talk about. So the estimate is that 4.4 of all emissions of greenhouse gases come from health services globally. According to the Directorate of Health in Norway, the proportion might be higher than 4.4. The estimate is 5.5 of total Norwegian emissions, and half of it coming from primary care, half of it coming from secondary care or hospital services. And then, of course, Norway, the level of emissions from Norway in total is very high. So taking that into consideration, Norwegian healthcare emissions per capita per country, Norway comes in the category to the second from the left, major emitters, tons per capita from health care. So there's a lot of emissions from healthcare, and it's significant in a way as a paradox that the world's health sector facilities emit these enormous amounts of greenhouse gases. It's significant, it's ironic, because our first commitment is to do not harm patients and populations, and therefore places of healing, health services should be leading the way to reduce climate emissions. So this quote from the Director General of the WHO. At COP26 in Glasgow in 21, there was a health initiative that was started with countries signing up, including Norway, to commitments to build, and here's the phrase, climate resilient and sustainable health systems. And Norway being the only country among the Nordic countries to participate, but in total, more than 50 countries have committed to this program. And in what is going on now, sorry about that, in Norway, as part of this commitment, the Directorate of Health is now finalizing a roadmap, veikart, mot en bærekraftig lavutslippshelse- og omsorgstjeneste, which is translation of climate resilient and sustainable health system, health system, helse- og omsorgstjeneste. So this, some of you might have commented on the draft in the, what's it called in English, høringsrunde. I did certainly, and it's due to be finalized and published in spring this year. Examples of activities to reduce emissions, low-hanging fruit. So propellants that are used in asthma medications are extremely powerful greenhouse gases. So per volume, they are thousands of times more polluting, and the greenhouse effect of those gases is 1,000 times larger than carbon dioxide itself. So initiatives to help clinicians and patients change from pressurized metered dose inhalers, from asthma spray, to those that do not use those greenhouse gases are an important step to reduce emissions. A similar one in hospitals, in surgery, to stop using certain medications for anesthesia that are extremely powerful greenhouse gases. These are two examples of low-hanging fruit to reduce emissions from healthcare. Now, I'm going to go from these examples to start talking about medical overuse. So here's a leap in my presentation, leap toward overuse, overdiagnosis, and overtreatment. Now, the OECD on this slide, OECD on this slide. In 2017, they estimated that 20% of activities or expenditure in healthcare systems in the privileged rich countries like Norway makes a minimal or no contribution to good health outcomes. So 20% is waste, it's overdiagnosis and overtreatment. This is new, and this is being charted as we speak. This is an estimate from the OECD. Another estimate is when I discuss this with my colleagues, when I ask Norwegian doctors, how much of the activity in Norwegian healthcare do you consider to be overdiagnosis and overtreatment that does not benefit patients and actually sometimes harms them? And here's an example of the answers I get. They say, so these are young trainees in family medicine and general practice, but the estimates are similar when I ask other doctors. So between 20 to 30% on average is their estimate. Oh, sorry, this is the estimate about how much of what they deliver in their own practice. Sorry, this was the wrong slide, but they consider themselves to be contributing as much as the average of in healthcare in Norway. So that's another estimate, a bit higher than the one from the OECD. Here's from a leading Norwegian newspaper last week. This week. We will soon all be patients, according to researchers Brodersen and Jönsson from Denmark. They came with this book last year. Soon we will all be patients. Medical technology producing patients and diverting resources away from those with greater needs for healthcare. What is my next slide now? Yeah. So I think this is challenging to conceptualize and to understand and to really accept that we are harming patients and we are being harmed as patients. So I decided to take the really well-known example that most of the public are familiar with. So antimicrobial resistance is a huge global problem, and overuse of antibiotics is a main cause of that. So here is an example of medical overuse that you probably are familiar with. Now, the challenge is that in a similar way, we overuse tests and treatment in almost all other fields of medicine. But it's a rather new issues, and you may not be familiar with a lot of examples. I'll see if I can blank my screen. So because I want to share another example, so another screen should be black because I just want to I don't have a slide of this. Norway has more MRI machines than any other country in the world per capita, or we conduct more MRIs per capita than anyone else in the world. A huge proportion of that are unnecessary, unhelpful investigations. And chances are that these unnecessary investigations come up with false positive findings that can be harmful. So that's another example. So I think it's the final slide about medical overuse, because before linking back to climate emissions, this is a rather new topic, but already in 1999, there's an important publication in JAMA trying to explain and discuss the unintended consequences of doing more and more in healthcare, how more might be worse. And in the figure to the right, it is an attempt to illustrate by introducing the law of diminishing returns. So on the x-axis, it's input of medical care, investment, money, number of physicians, number of nurses, whatever. So the benefit in the beginning is proportional to new investment. You add a new doctor, and doctor number 10, the return of going from 9 to 10 doctors is equally great as going from 2 doctors to 3 doctors. So there's a linear relationship. Now, very often when we invest more and more, there are diminishing returns. And in this slide, the author suggests that the net benefit of introducing more and more healthcare might sometimes be negative. And with my colleague, Professor Getz here in Trondheim, I'm speaking from Trondheim today, even if I work in Bergen, we've been thinking about the possibility that we may now be in situation A, where we have invested so much. So if it's correct that 20% of more of what we do is waste or even harmful, there might be net harm from some of our investment. and the question being, how can we get back to point B by reducing medical overuse, and the risk that more medical overuse might cause more harm and overburden the system in ways that are not sustainable, to draw on the sustainability concepts. If it's unsustainable, we might reach a tipping point. T for tipping point might lead to system collapse, and that's why there might be even one more slide. Yeah. No, sorry, linking now, starting to link to between health services that are mainly intended to contribute to SDG number 3, good health and well-being, and then linking to, because the SDGs are connected always, highlighting now link with number 10, responsible consumption and production, and 13, climate action. So if some of the activities in healthcare to provide good health are include irresponsible consumption and production, and lead to climate emissions that really contribute to the climate crisis, then we have a problem. And here's the last time I'll show this graph. So if we are here, then action to curb medical overuse would be good for healthcare and public health and population health and patient health, but it would also contribute to SDGs 12 and 13, this thing here that I'm interested in. And then finally, about initiatives. Oh, sorry, here is a slide about this, the tipping point idea that the universal health care, norske helsetjenesten, may be under threat due to unsustainable resource use. Here artificial intelligence has helped us to visualize this welfare system, the universal healthcare system in Norway, and there are some huge animals, or there are threats to the diamond. I don't know if the metaphor holds, but you get my point. We've been discussing this and writing about it in this project that's called Sustainability in General Practice. I'll skip this one because time is running. I'll get to, sorry, oh, my slides. So here is the initiative, Choosing Wisely Norway. Choosing wisely Norway, gjør kloke valg at the bottom. Gjør kloke valg meaning choosing wisely. We are talking that about more not always being better. We have a national campaign against overdiagnosis and overtreatment. It's the Norwegian medical societies that's behind this, whereas choosing wisely is an international movement starting in US and Canada. But we've been incorporating this in Norway for 6 years now. This is an example of information towards patients. I hope, yeah, so we have more than 140 recommendations for healthcare professionals to help them to avoid medical overuse. And then, because I'm being speaking for too long, I need to skip a couple of examples. I'll show you a video that goes for 40 seconds, and then I'll show examples of information material that links overuse and climate. So that's my last part. Here is the video. It starts very nicely with a flower, but be aware, it should be rated, adult rated. There are tough scenes in this video. So you should, how do you say in English, stramme magemusklene, it's tough. So it starts nicely, but be warned. So our way of visualizing harm from medical overuse. And I'll just give you a final example of, so here is the climate poster for general practice that we have distributed to all GPs in Norway. And the final one is, so sustainability in general practice. Oh, sorry, I haven't translated this into English. Avoid overdiagnosis and overtreatment, also because it will lead to less emissions. And then to the right, the case of inhalers. So that's ongoing work to help GPs avoid medical overuse and linking it to climate. So that's my final slide. Sorry about being speaking for so long. Thank you.
Thank you very much, Stefan. And you have not been speaking for too long, so that was perfect. I was very curious about the slides you didn't show us anyhow, but we probably will get them so that we can see them later. I just want, since we are not so many, if you want to put your cameras on and or just have a question, you can either raise your hand or you can write it in the chat as you wish. Like here, I'm just typing here so that everybody gets it. While people think, I wanted to ask you something, because there is a lot of energy and new what the European Union is trying to do, and what we are seeing very much, is to try to make this link between climate change and health, so that people get more aware of climate. So in a way, using health as a way of telling people that climate is dangerous for us. And you show us another way of looking at this, how health care and health care use can be also linked to more emissions. This is not that climate is doing that we get our health is being poorer, but the opposite way, in a way. But I wonder, there is a danger here in the rhetorics and how you take this further. Whose responsibility this is? Is it the patients? It is the general practitioner? It is each doctor? It is the system? Because the danger, if you don't get this right, is that people get even more. Okay, I can't do anything, right? So do you have any ideas on this when you give this message? How it can be given in a way that it's possible for and positive for public awareness, and not only generating poor conscious and a feeling of I can't do anything with it.
Yeah, I think my first answer would be that, so in choosing wisely, we are used to dealing with this communication challenge. So if you say to a patient, no, actually, I'm not going to take that test, and if the patient thinks that this is being done because there aren't sufficient resources, or my doctor is keeping something away from me that would have benefited me, then the patients are going to be angry, and they will complain, or they will turn to the private sector where they get what value for their money or whatever. So the communication challenge is to explain that this is in your best interest. This is being done not out of prioritization. How do you say? So not because we don't have enough resources to give you what would have been good for you, but actually because less is better. And I think somehow it's the same here, that health services that harm that harm climate, they're going to harm you too as a patient. But it's a huge challenge.
Yeah. Very interesting. I see we have already 2 questions, one from Susanna and one from Anders. Susanna, you want to pose it yourself, or shall we just read it? I can. Yeah.
You can
Yeah.
read
Here you
it.
are. You can just pose yourself because it's always easier, and then Anders, you can do afterwards.
Right. Do you know, I mean, is there any research related to the distribution of health services? What should be where should we build these gigantic hospitals, or who should be traveling? Is it the patients or the doctors, and all these logistics related issues? It's partly about health economics, but it's also related to climate and emissions and that kind of things. Do you know anything about that? Is there any research related to that?
So I don't know much about this. What I do know is that due to the pandemic, health services were required to deliver a lot of help remotely, and there's a lot of interest in taking that forward. A lot of remote care being delivered. There's been some pushback, and the pendulum goes in both directions. So like in general practice in Norway, we don't provide a lot of remote care now, even if we were able to do it during the pandemic. And research shows that increasing access by providing digital access, it has a lot of consequences, including making it easier for people to chat with their doctor about some details of which nutritional thing, what do you say, that I buy at the grocery store, do you think is the best? So people are chatting with their GPs about unimportant stuff. So GP activity is being driven towards medical overuse through digital access. I know this is a very, very partial answer, but digital access can have a lot of unintended consequences.
And like an e-consultation, it's not without climate impact if you compare it with traveling to the doctor. So it's really what do you include in your calculations, and is it the narrow picture or the big picture, and yeah. Who do you ask? I mean, who defines what is unnecessary? What is unnecessary for the patient or for the medical doctor may not be unnecessary for the patient. So it's complicated, I think. Thank you for the answer.
Anders first, and then I see Marit and Audun have raised their hands. So just go one out after the other. Anders.
Thank you, Stefan. I was just curious. You said that 5% of global emissions come from. What would be your guess about how much we can realistically reduce this?
I think there's a problem with them. Did you understand, Stefan?
Yeah, and I've read it in the chat also. So thank you, Anders. So as a thought experiment, if 30% of all activity in healthcare in Norway is waste, frankly, literally waste that also harms patients, we should stop doing these 30%. And I'm not aware of how much of emissions come from these 30% of activity, but it obviously might be somewhere close to 30% of emissions. Now, this is not going to happen today or tomorrow, but and then the other answer is that we need to get to net zero as fast as possible. So we need to change healthcare delivery so that important services that we should continue providing, that they do not produce net emissions. But as low-hanging fruit, we ought to stop overdiagnosis and overtreatment, because it's not hard. So stop not delivering those services would not harm patients at all.
Marit?
Again, Stefan, very interesting this, but looking at the political part of this, which I think is very important, because the GPs has been thinking about this for long when we got the antibiotic guidelines and less use of antibiotics and the correct antibiotics, not using antibiotics, and we also got the patients with us. Patients in Norway are actually very they know why we don't give them a prescription, because we tell them.
Yeah.
The things you now tell us is that how can this use of the MR, the X-rays use, the ultrasonic use, the referral to hospital to specialists, how can we use the knowledge we got about the antibiotic resistance to let people be with us and to make them literate into this, to make them the knowledge about this. Why? Because on the other hand, the hospitals has offered even more and more sophisticated tests, sophisticated equipment to tell things, and so has the private sector. So I think this is very important, and the more you use, the more waste you also get with gloves, with all the other waste things that we should measure today. So how do you think that we can get this message on, as we did with the antibiotic resistance message?
So I've been thinking a lot about this, and I've been trying to find research that answers the question. So what have been the keys to the antimicrobial resistance success? So how did the public come on board? What activities, which initiatives have been crucial to getting the public in a country like Norway? And if anyone here knows about research that sort of has explored not just antimicrobial resistance awareness among healthcare personnel, but out in society, I would like to know, because we need to learn from that success story. One part certainly is that healthcare personnel across specialities and the authorities were united. So it was not GPs saying we need to be more careful with antibiotics, and hospital specialists saying something different. No, the message came from everyone, including healthcare authorities, and that we need that when it comes to medical overuse in general. So and that's why it's super important in choosing wisely, that it's all the specialties within medicine and all healthcare professions in Norway unite in this message that more is not always better, because otherwise it will not work. But that's only a partial answer.
If I may say something here before we give the word to Audun, is that here it might be when the climate issue might help, because it might have not been that very used at the time with the antibiotics, but if posed in the correct way, it can also, at least for part of the population, be one more reason to be within that. But of course it has to be done carefully, because otherwise the patient, as you said, Stefan, can think, well, if that's because of the climate, I want my knee to be explored anyhow. I don't care, right? So it's how you do it, but it might be an ingredient which is new and which could be used.
Thank you. That's very interesting.
Audun?
Hi, thank you so much for this seminar and for organizing this lunch seminar. It's interesting to listen and to hear your insights, Stefan. I was really intrigued by the graph you showed about diminishing returns in healthcare, and coming from a priority setting perspective, and perhaps I am reading you wrong, but I think your answer to the first question was that this is about medical overuse and not about prioritization. So if I may just make that assumption in what follows, I wanted to say that I was thinking about, if we make the switch from A and back to B, that is also about prioritization. And it is important to be transparent about that, because some patients are on the individual level going to be worse off if we are more restrictive if we become more restrictive in our practice, in diagnosis, or in things that we see on a population level are perhaps futile or less effective measures, but that on the individual level could be quite effective. So I think it is not to play further on these economic terms, it is not a Pareto optimal thing to make the switch back to B. It is a sensible thing, I think, to do, but it is not necessarily something that improves the situation for all patients in Norway. And you could even argue that on like a national scale, that Norway as a country is more apt to deal with climate change than other countries. So we would be less affected by this increase in climate change. And then patients in Norway would perhaps, if we only talk about medical overuse in the context of climate change, the benefits are also reaped elsewhere. And I think it is important that we commit to climate change. Of course it is, but there are, and it comes back to the political as well, that it's easy to say that this is not just about overuse or about doing less to prevent harm, but it is also about doing less to prevent climate change and to put our resources where they are the most needed. So I think something that could really, it's just an initial thought, but something that could really exalt or further strengthen this thinking is also to link it to the priority setting criteria, that we, by making that switch, we preserve the scarce resources that we have in healthcare for the worst of patients, for the cases that on a population level are most important to address, still cutting climate greenhouse gases where possible, where less cost effective, so to say. I know that is perhaps not the wording of the Choosing Wisely campaign, but I think there's an interesting link here, and that could be enhanced. So it's just some thoughts, and perhaps you have some comments. Perhaps I'm off, but thank you again.
Can I comment, Esperanza, briefly?
Sure.
Yeah. So actually, Audun, I think you're off. I think this is wrong. I think we are in different fields here. So there is the question of tests and treatment that will benefit patients, and the situation is we don't have enough resources to provide it all, including healthcare financing, healthcare personnel, or our planet. So we have a finite resource, which is our planet, and if we provide all healthcare, it will harm the planet, and without the planet, we will not be able to. So that is a priority setting situation. I agree with you in that. Whereas what I'm speaking about is situations where we are providing healthcare that does not benefit the patient, and that actually, if it affects the patient, it will harm them. And that is not as far, I mean, I'm not a priority researcher. I don't even know the Pareto optimal that you mentioned, but the way I understand priority discussion is about painful decisions about what out of those things that will benefit people can we afford to deliver. Whereas overdiagnosis and overtreatment is in a way plain stupid, because we are harming people. And if I take the test, it's not going to help you, and so it's waste. And if anything, it's going to harm you out of overdiagnosis, false positives, and cascades of more testing and overtreatment. So in that way, sorry, it was rude of me, but I'm saying in that I think these are two related, adjacent, but different areas. Prioritizing between good stuff, but whereas what I'm talking about is stop doing the stupid stuff. Sorry, it was a bit long.
Well, thank you. No, it was. I think this is very interesting conversations. We have to close down, but I will advertise for two things that might be of interest for you, especially following this conversation. On the 23rd of January, the pandemic breakfast, we will have Oddvar Karbe, who's going to talk about new ways of modeling climate into health in a way that, for instance, hospitals can't choose things depending, adding a cost to the climate impact. So that will be kind of linking the two of you that we're talking now. And I wanted also to advertise for in the Bergen Summer Research School, we have a course for PhD students about climate and health. And some of you here will be teaching there as well. And the deadline to apply for that is coming soon. I don't remember exactly the day, but this will be happening in June, starting the 10th of June. So I want to thank Stefan for a very interesting presentation and all of you for your comments. And I hope to see you again in our next webinar, which is on the 14th of February. And that will be about climate it will be about adaptation to climate change and social differences as well, because we have also